All right. Hello, everyone, and welcome to our final town hall of the year. We're so excited to kick off today's discussion, which will focus on driving DCD performance through specialized hospital teams. My name is Deanna Fenton, Program Manager here at the Alliance. And as always, it's my pleasure to host today's program alongside our moderator and panel presenters. Now, before we go ahead and begin, I'd just like to review a few housekeeping items for anyone who may be joining us for the very first time. Upon joining us for today's town hall, you may have noticed that your audio lines have been muted. Please note your lines will remain muted for the duration of the town hall presentation. That said, all questions or comments will need to be submitted electronically using the Zoom Q&A feature. For those of you who submitted questions during the registration process, please know that we've done our best to compile your questions and we'll have our speakers address them throughout the course of the presentation. Should you have any additional questions, please feel free to submit them using that Zoom Q&A feature. Now, following the conclusion of today's town hall, you will all receive an email from us with outlined instructions on how to access our post-town hall evaluation. Unfortunately, while continuing education credits are not offered for this program, you will have the opportunity to claim a certificate of completion as a result of your participation. We highly recommend that you complete these evaluations as it's your feedback that will ultimately help us to develop future programs that suit your needs. If you have any questions, please don't hesitate to contact a member from the Alliance team. As an added note, we will be recording today's presentation. So if you or a colleague is interested in viewing today's town hall at a later date, you can access the recording on our website at organdonationalliance.org. There, you'll also find information about our upcoming programs in 2021. Now, without further ado, I'd like to go ahead and begin today's discussion by introducing our moderator, Meg Rogers, Director of Transplant Center Relations at LifeSource. Meg, thank you so much for joining us today. And at this point, I'll go ahead and turn it over to you to introduce our speakers.
Yeah, and thank you so much. It's my pleasure to be here and be joining you today. And it's my pleasure to be introducing two incredible speakers here with really quite some remarkable work that they have done over several years of focus on improvement and innovation. Before I introduce our two speakers, what I would like to do is ask Dan to pull up, we have two polling questions. So let's pull up that first one. And while I introduce our speakers, you can be responding to that first poll question. So there I see it's on the screen. How many DCD donor cases have you participated in over the last year? Our speakers today join us from Pittsburgh, Pennsylvania. I'll first introduce Kate Sperling, who is a programmatic nurse specialist in neurological trauma critical care at UPMC Presbyterian. As a clinically focused PMS, Kate works with the Level 1 trauma program and the Comprehensive Stroke Center to improve patient care and outcomes. And as you will hear during this presentation, she functions as a nurse champion for organ donation at Presby, and I almost want to say a Wonder Woman there. Amy Weisgerber is the Center for Organ Recovery and Education's in-house coordinator at UPMC Presbyterian Hospital. Prior to joining CORE, the OPO that serves Western Pennsylvania and West Virginia in 2009, Amy worked as a donation clinical specialist at Life Gift in Houston, and she's a graduate of the Human Donation Science Program in Toledo, Ohio. Welcome to our two presenters. And I will ask Deanna to close that first poll question and show us our responses. So, quite a spread there. So the majority of responses are 3 to 6. And we have a fair percentage, 28% at 11 plus. So fair amount of experience here. Okay, we have one other poll question before we get started. What is your role in the DCD process? Bedside nurse, hospital physician, OPO staff, OPO administrator, or something other than that? I know we have, from looking at the list of participants, we have over 300 people joining us today, and from a variety of specialties, as we'll see as these questions are responded to. And why don't we go ahead and close the poll and see what we've got. 61% from OPOs. Couple of hospital physicians and then a few others, OPO administrators. So that gives our speakers a great deal of information to focus on as they go into their presentation. We can take that poll cover off and, you know, I live in Minnesota, and in Minnesota we have pretty vicious winters, and in the summers we have a lot of heat. And when it comes to the end of our, you know, 20 below plus winters, one of the challenges is in driving down the road is the potholes that we encounter. So they are many, and trying to avoid them and prevent them and fill them as quickly as they come up is a goal. And what we are going to hear from our two speakers today is what they have done in driving DCD performance through specialized hospital teams to go from that pothole to the pavement.
Thank you so much.
Amy.
Yeah, thank you, Meg. You know, for those of us who are on the line, I think the same struggle that you guys have in Minnesota, we have in Pittsburgh with our roads and potholes. We actually had one that was big enough that it swallowed a bus. And we're just really delighted to be here today. Thank you so much to the Alliance for having each of us. As you've heard, Kate and I have worked together really since 2009 when I returned to Pittsburgh to work at CORE and help fulfill our mission to save and heal lives. But it wasn't really until 2012 that Kate and I collaborated in our current roles. And I think up until that time, our programs both kind of thought like, you know, we had the city of Pittsburgh, city of champions mentality, and we let that sort of permeate our view on DCD, thinking, you know, we're pretty good at this. And when we really took a closer look, we thought, there really are a lot of potholes in this process, and there's a lot of the bumps in the road that we should probably smooth out. And that's really when we started the long journey of repaving and overhauling our DCD process.
So I'm Kate. Thank you again, Meg, for having us in the Alliance. And as Amy said, UPMC Presbyterian is a high donor volume hospital. We are partnered with a really great organ procurement organization, CORE, the Center for Organ Recovery and Education. And we were trucking along. We were converting patients from potential to actual DCD donors. We were recovering organs, successfully transplanting them with the OPO and the transplant teams, yet we had bumps. We really got to the mindset of thinking, this is fine, everything's fine, this is our norm. Yet when we did a deep dive, we really recognized that we had some infrastructure issues that merited repaving. So what we did was a deep dive. We got out all of our equipment. We did some detailed retrospective chart reviews of all DCD cases from 2010 and 2011 donors, and really tried to make sense of all the data and the findings that were popping their heads up. And we classified the critical errors into 3 domains: charting, both nursing and physician documentation of the care and of the process of DCD; medications, including controlled substance, availability and handling, as well as availability of heparin for the intraoperative portion of DCD; and body release. Body release was oftentimes we found to be problematic, releasing bodies timely to the OPO for tissue donation, to the medical examiner or the coroner if they were assuming jurisdiction, or to our community partners of the funeral home, and then also autopsy cases that were staying in-house for our UPMC Presby autopsy team to proceed with their work. And we recognized that we had a lot of issues with that timely release that ultimately impacted the potential for someone to be a tissue donor and delayed transport to the funeral home for a grieving family. So we really, after getting all of this information, knew some of the big infrastructure issues of where we really needed to repave.
And so we kind of took a look at our team and said, all right, who is going to be part of our crew that's going to help us kind of smooth this whole process out? And from the OPO standpoint, we always have a bedside nurse as part of this DCD process. And so that was a constant for us as we looked to make some improvements, is the role of the bedside nurse and preparing that nurse. But where we're very fortunate at this institution is that we also have a couple extra tricks up our sleeve and a couple extra helpers. We're very fortunate to benefit from a group of physicians called the Organ Donor Support Team. This was something that was started a number of years back by one of our critical care attendings, Joe Darby, and he has really done a great job of finding other critical care attendings who are interested and invested in the donor process. And this group of ODST physicians provides around-the-clock availability for intervention, management, and support of brain dead and DCD donors. They also are a great interface for peer-to-peer education with other physicians. We have, and this is our secret weapon, Kate Spearing. She won't openly admit it, but I do have to agree with Meg's assessment that Kate is Wonder Woman. She wears 1,000 hats here at this institution, just one of them being the donor process. She is more than a nurse champion. She is a leader and a role model within our own institution. And her work has really transferred across our UPMC system hospital. We have over 16 hospitals, and Kate is the system kind of appointee for all things donor related. So she really is a true leader. She's very invested and very tied into the work that's happening in the ICUs. We're very, 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 very lucky to have her. She is singular in the work that she does with donation. And then at our institution, because as Kate said, it is really kind of a high donor volume hospital, we account for about 27% of CORE's annual donor volume. We did put in place a number of years back an in-house coordinator role that we've also just recently expanded to a nighttime hospital-based procurement coordinator. So we have a pretty big crew, and we knew that once we had our crew and we knew kind of what potholes we were trying to target with these critical deviations, it was really time to get to work.
So we recognize that there were lots of steps in this process, and we're showing you many of the steps. However, we want to just highlight a few of these. We knew from the deep dive that we did that the majority of our issues were medication related initially. So we designed and rolled out the DCD drug box. And our intent was to fix the availability of controlled substances for symptom management at end of life, as well as improve our documentation and the handling of these substances, as well as have that heparin always available. It was always a roadblock calling pharmacy to get 60,000 units of heparin for DCD cases at 3 o'clock in the morning. So we developed this DCD drug box and really thought that that was our ticket to success. When we rolled this out, I was present for all of the DCDs, training the bedside nursing staff on the drug box, and things were going along fine. And then we ran into a big road bump, big pothole we had a case where the nurse, myself, was not available and the wheels came off of our car. We had significant deviation in all critical elements of nursing documentation to medication handling, reconciling of controlled substances, as well as a delayed release. So what we learned from that was really proof of concept that the expert nurse, being the foreman of this hospital-based crew in partnership with the organ donor support team physician, could really make the difference in smoothing out this process. So Amy and I quickly wrote up a proposal to hospital administration, gained approval for staff availability as well as financial reimbursement of the staff to develop the RNDCD team. We developed training with the OPO, the organ donor support team, used a SimMan concept along with simulated family members, and trained our nursing team, which consists of 6 nurses. And since then, really, it's been relatively smooth sailing. Current state, our DCD team has 6 DCD nurses. We are available 24/7 to cover cases. We can be in-house. Oftentimes, one of us is here, or we can be in-house within 30 minutes to an hour. We do annual training. Any new nurses that join our team, we have an onboarding process. And as Amy had highlighted, thanks to the work of Dr. Darby, the founder of our organ donor support team, and now our two co-medical directors, Dr. Elmer and Dr. Melano, who are engaged on all of our organ donors and especially vested in the DCD process, we have really been able to smooth out these bumps. We have a physician who will pronounce, we have a checklist that we follow to capture all of the required elements of the process. And really, following the ODST concept, that really fueled us to mirror and create the RN-DCD team. And you know, we got to this point where I wasn't sure if I was just living so much DCD from all of this performance improvement, or if our case mix was really increasing. And I said to Amy, can we take a look at the numbers? Because I feel like we're doing more DCDs. And lo and behold,
we actually were. So the interesting and kind of incidental finding of this is that our case mix of DCD to brain dead donors actually increased following our final implementation, this final phase for our go live. So that prior to our intervention, we had about a 23% case mix of DCD. And afterward, we really average about 30% of our overall donor volume being DCD donors. So you can kind of see not only has our program had growth in the last couple years, and again, this will be another record-breaking year for our institution and our OPO, but we've also really been able to grow the DCD volume. It was important to us when we saw some of this data that we really stopped and said, are we sacrificing any of our brain dead donors to pursue a DCD pathway? And when we went back and looked, the answer to that really is no. We're not losing brain dead donors to the DCD process. What we have seen in this growth of DCD is that we're making donation happen in cases where it's DCD and oftentimes DCD very quickly or not at all. And in fact, our DCD average that you can see kind of tracking in this orange line really does pretty much correlate with our OPO volume as well. It tracks a smidge above, but not statistically. So we're able to offer donation to more families. And that's really important, not only to our mission as an OPO, but also the service that we provide as a really integrated team at end of life. And when you look at what that looks like in actual terms of raw numbers, you can very clearly see over the progression of time that donation has been an opportunity for families that it may not otherwise have been. I had mentioned that some of our cases, it's kind of DCD now or not at all. And we've had a couple case times. Now, we're not far from course headquarters, but we've been able to make it to the OR from the trauma bay to an OR time in under 4 hours. And a lot of this team has allowed and liberated the OPO group to focus on our OPO tasks. So getting coordinators to the hospital, getting through the paperwork with the donor family and supporting them emotionally, mobilizing surgeons and recovery staff, and then also making sure that the team knows what to do. And with this DCD team in place, we are really able to entrust that critical part of this process to the DCDRN.
With our innovative team of the DCDRN and the organ donor support team, we can really guide that hospital care. We can have an effective huddle. We can very clearly prep the bedside nurse and respiratory on their role. Perhaps it may be their first case because DCD is not an everyday occurrence. And our DCD nurses can just make sure all the minute yet critical details, things even as small as making certain that the EKG leads are on the back, or that we have the power cord for our transport cardiac monitor, to ensuring that all those essential supplies for compassionate end-of-life care are readily available for that transition to the operative suite. The DCD nurse is really crossing those I's, or dotting those I's and crossing those T's.
And I think that that element especially really increases the buy-in from our hospital team members, because the DCD team has done such a great job of educating bedside nurses and making them feel prepared and confident and competent to be in that intraoperative setting. We really see that they have an increased level of an engagement and a buy-in to our OPO mission. And what it looks like in the ICU is exactly that. A lot of collaboration, a lot of communication. What you can see in this first photo on the left is Kate spearheading the ICU huddle that's taking place with members of the team who will be participating in the DCD. we developed, as Kate had mentioned, a specialized checklist that is multidisciplinary. It's kind of a safety hall pass. And it's something that we review before we leave the ICU on every single donor. And it's just one part of this process.
The picture in the middle is one of our DCD nurses accessing one of 4 DCD drug boxes that contain our meds for end-of-life care in the operative setting, as well as the heparin. Oftentimes we will get perhaps 2 boxes out just to make certain that we have enough medication on hand. And in his left arm is our donation after cardiac death bag, which contains all of the supplies, things like extra EKG leads, syringes, needles, tissue for when family members are present. So the nurse can really have everything at his or her hand and focus on the care of that patient and family.
Yeah. So I think we've left enough room, Meg, for you to come back. We've tried to answer some of the questions that came through in the registration, but certainly happy to hear from you and some of your experiences as well.
Thank you both. It was an excellent presentation, and clearly it seems like each of those boxes that you showed on your flow of what you have done to build to this point probably could be almost a town hall in and of themselves. There have been some questions coming in, and the first question that I want to start with is you had to get hospital support to develop the DCD RN team. How was that process, and how did you make that happen?
So we made that happen in collaboration. Amy and I wrote the proposal up and bounced it off at the time our medical director for the organ donor support team, Dr. Darby, and then took that through my boss. And the beauty of that relationship is that my boss has a long-standing history. At the time, she was my supervisor of organ donation, and she was able to really intimately understand the process of DCD, knew all of these pitfalls and barriers existed, and was easily able to give us the green light to proceed with using identified salaried nurses from our higher volume donor units, our neurotrauma intensive care unit, as well as our neurosurgical neurovascular intensive care unit. And she had run that by, at the time, our director of nursing, and there were really no objections. Our nurses, when they come in, are typically here anywhere from 4 to 6 hours, and their time gets charged to the cost center of the intensive care unit of where that DCD patient is located.
Yeah. And we had asked also, as part of this proposal, each unit director to kind of vote and voice how they would want to use a support nurse. Would they want the DCD nurse to come in and assume total care of the patient? Would they want a helper? And so we really had a lot of unanimous, not just administrative support, but kind of leadership and frontline support from nursing as well in what this role would look like for nurses.
That's
great question.
Great. Deanne, I see we have a lot of questions in. Do you want to remind people how to submit questions if there are others who want to submit?
Sure. As we transition into our Q&A discussion, for those of you who may have some additional questions, feel free to submit them using the Q&A feature. For anyone who may not be familiar with Zoom, that's going to be located at the very bottom of your screen. You should see on the right-hand side an icon that says Q&A. So you can go ahead and submit your questions there. And then in addition to that, while we facilitate this Q&A discussion, I'm going to have this poll up. And so I'd just like to ask for those of you who are participating maybe as a group, if you could just complete this poll and let us know how many people are participating in your respective group, that would be great. With that said, I'll go ahead and turn it back to Meg. Thank you.
All right, thank you. So we have a question that came in from Richard Zapata. In the case where you went to the OR in 4 hours, did the donation happen at a transplant hospital? So is UPMC Presby a transplant hospital?
It is, yes. Yes, it is. So we were very fortunate. We have a transplant program for all solid organs here at Presby.
Okay, so your surgeons were kind of right available.
Well, it was Saturday.
help make that?
It was like Saturday afternoon. It was beautiful outside. So they weren't really in the building, but we have a really great relationship with our surgeons, and we were able to kind of phone a friend and implore and beg for quick response. And our surgeon is great and just kind of said, yeah, how's it been, and help you guys out. We had a great response from an AOC. And we called and kind of said, this could turn into something. Why don't you just move a team? And it just ended up working out really well.
And on the front end of that effective huddle, having the agreement, because the patient was very unstable, communication between the organ donor support team physician who was assuming the care of that patient and the trauma attending, saying, yes, we will resuscitate, we will give 2 more units of blood, we will do 1 more round of compressions, and having that clear plan with the target of getting to the OR as quickly as possible. Yeah. I think all supported that quick turnaround time.
It was a highly effective referral as well. We were in place waiting for the patient to arrive from the helipad when they got there. So we were pretty much ready to roll.
Okay. From Matt Groveman, have you seen an increase in potential? Have you seen an increase in potential and/or authorization since the start of the expert nurse project? So has the consent rate or authorization rate for donation gone up?
For DCD specifically, I don't think so. I think our authorization rates have held pretty steady. We have under the old criteria, we had about a 96% conversion rate from an authorization standpoint, and that's been pretty steady. The biggest factor that we see for authorization rate is the effective communication from our physician team. Because many of our ODST physicians also attend in ICUs, they're highly skilled communicators and able to facilitate that transfer, and also able to guide the OPO to when that communication and when that conversation would be best timed to maximize the family. So it's rare that we're running into scenarios where families want to withdraw, they came in all today and they're ready to withdraw right now. We're really able to work with nursing and physicians to time those conversations so that we can increase the likelihood of certainly a DCD authorization, wouldn't you say?
Yes, I would completely agree. And I feel like since we've smoothed out a lot of the bumps in the road, that what that has done is allow the OPO the opportunity to potentially offer the opportunity for that family to have their loved one be a donor.
Yeah, I agree.
So that sounds like a really critical team.
We're very lucky.
Yeah. So the next question that has come in is kind of along those lines. Ruth Sonnenberg asks, how did you put together the ODST? Was this physician driven or was it initiated by the OPO?
Oh, that's a great question.
So,
I will remind everybody that was back in 2013?
2008. So it started in 2008.
Yeah. Okay.
Yeah, the ODST started in 2008, and that was really Dr. Darby.
And I think it was a love of Dr. Darby at the time, very interested in post-cardiac arrest patients, neurotrauma patients, dealt with a lot of severe traumatic brain injury, and had a particular liking to caring for that population and was very supportive of organ donation, and recognized that that was in many ways an underserved patient population that oftentimes would be admitted for CMO. And he started admitting those patients to his service and really collaborating with core leadership at the time to potentially resuscitate that patient, get them physiologically stable, be able to pronounce them, and allow for that opportunity of donation to happen.
Yeah, so we saw, and the ODST team here actually published a couple of years back their results. We saw organ yield increased compared to a study period prior to ODST. They come in and manage every single one of our brain dead donors. It's not our coordinators here who manage that. And so we saw an increased organ yield. We were noticing that We were also able to recover more donors, patients who might have otherwise, not been great hemodynamically. Their knowledge really played a big role. And those of you who may have worked with Dr. Darby or his colleague, Dr. Powner, down in Houston, Dr. Darby has a real presence and a charisma and was able to recruit other people to carry this torch alongside of him. We have a highly integrated teaching institution here. So fellows are great learners and they're highly exposed to our ODST team. And they really kind of grow up in the system of organ donation as a norm. We teach them across multiple different service lines from trauma, neurology, neurosurgery, critical care, and pulmonary critical care throughout points of their training. And they all receive routine and regular follow-up when they're involved in a donor case. So over time, the culture has kind of been built and self-perpetuated that this is a standard of care, and participation in this process has value for the patient, for the donor family, and for the institution.
Great. We have a whole queue full of questions for the two of you. And I know we're officially at our time now, but I think we can probably go a few extra minutes, maybe 10 extra minutes. Does that work for you, Kate and Amy?
Yes.
Okay. So from Brittany Dunn, how many MDs do you have on your team? What service are they from? And can you share your multidisciplinary checklist that you use?
Yes, we could share it. Meg, will Brittany be able to send her email somehow? We have, and we could
perhaps even sharing on the Alliance, we could work with the Alliance to share on their site as well.
Yep, we have 5 critical care medicine intensivists who are active members of our organ donor support team. They attend, as Amy had said, in the neurotrauma and neurovascular critical care units. One of them crosses over to emergency medicine also, and one of our intensivists also crosses over into stroke neurology, as well as some post-cardiac arrest.
Okay. And could you review again, what are the specific events that you classify as critical element deviations that have declined to 0 in your tracking and trending?
Sure, absolutely. So we classified our critical errors into 3 buckets of documentation, both nursing and physician, and making certain, I can go into a little bit of detail about that. Before we had the checklist and some of these details worked out in education, we're giving controlled substances at end of life. It's the only piece of documentation in our hospital that remains on paper. Otherwise, we are all electronic. So making certain that there are orders for extubation, the heparin, any of the end-of-life medications that we are delivering or administering. The nursing documentation from accurate transcription of vital signs according to our hospital policy every 5 minutes during the case until the patient is agonal. We transition to Q1. Medication documentation, wasting, reconciling the safe discard of that medication, and the availability of the heparin was another bucket. So we have charting, physician and nursing, and the medications. And then our third critical element bucket was body release, ensuring that we were good community partners, honoring what that patient and family had wished for either autopsy, tissue donation, or if the ME or coroner was assuming jurisdiction.
Yeah. Okay, thank you for that. Jim Boggs asks a question. It's stunning to have the nurses be both competent and confident. Competence may be the easier part. How do you address their confidence and buy-in? Great question, Jim.
Great question. So I think that, making sure nurses feel confident in the process, I think the DCD nurse has a ton to do with that in terms of validation, but we educate a lot.
And we have had some turnover from our initial 6 members. We've had 3 new members join our team, 3 people leave, and a 50% turnover rate. because, you know, there's a lot of opportunity. People go on to school or take different positions. So myself and the other 2 nurses that have been on the team since its inception are very dedicated, and we always, when we onboard a new nurse, do our hands-on training. And then one of the 3 long-term DCD nurses are always available to do cases and sign that DCD nurse off until he or she is truly comfortable. That may be 2 or 3 cases that we will come in and walk alongside our DCD nurse who is orienting. And I think the real beauty of this team is we always, as a DCD nurse, spend time prepping the bedside nurse for what to expect. We have a lot of new nurses in our institution. We're a quaternary center. A lot of our nurses come here, get experience, move on to travel, or pursue anesthesia or nurse practitioner programs from our 8 critical care units. So I have nurses who have been a nurse for 6 months, the whole way up to 3 decades, and trying to make certain that they are all comfortable with the process. Many of them are comfortable with the nursing care, but it's removing them from their resource-rich environment and putting them in that operative setting that we are very thoughtful of what they can expect to hear, what they can expect the environment to be like, and that we have all of our resources and anything we need to take care of that patient still with us. Yeah. Really growing their comfort level and promoting that culture of donation through that, because if they're comfortable with the process, they're very supportive of and willing to be involved in that next case and make the referral.
I think one of the other
Thank you, Kate.
Yeah, I was just going to say, just to add on quickly, is that Kate or I review all of the documentation from every single case. So each nurse on the DCD team gets immediate feedback that, hey, everything was perfect. You did a great job on your documentation. Or, you know, we do in-person case reviews and follow-ups within 24 hours in the ICUs, and then again via email. So nurses are hearing quickly how they performed and getting targeted feedback if there were any missteps.
And they're also making the connection, and it's more global, of the care that I'm providing to this dying patient and his or her family is bridging and saving a life of a recipient. So they're seeing a lot of value in the process. Yeah.
Great. So a lot of hands-on resource. So as I'm going through these questions, there are so many questions to get to. There have been several comments of great presentation and excellent, love the team. So I don't want to overlook those, but I want to stay focused on getting to as many questions as we have. And Trish Carroll just asked a couple quick questions here. Can you clarify if there are 1 or 2 DCD RNs on each case? And do the DCD RNs declare death as well?
So great questions. There is only 1 DCD nurse on the case unless we are orienting a new DCD nurse, but typically 1 DCD nurse who is guiding the bedside ICU nurse. No, our DCD nurses do not pronounce. Our organ donor support team physician, our critical care medicine attending, is the pronouncing physician who pronounces and certifies death.
Okay, thank you for that. This is from Daniel Stanton. Does UPMC transfer any donors, brain dead or DCD, from outside hospitals for management and organ procurement?
Are you a
That's
mole?
a great question.
This is a hot topic. We do receive a high volume of patients from outside hospitals. Last year, we had 76% of our donors were flown in from an outside hospital. The remainder of patients were transferred from scene. Some of that is because, you know, we offer, you know, around the clock neurosurgery, and we have a very, you know, very productive trauma service.
Level 1 trauma center, comprehensive stroke center. We are an ECMO capable center, an LVAD center. So we are the quaternary care institution in the tri-state area for Western Pennsylvania.
So they're transferred for care, not necessarily for donation.
We Correct. Have had 1 or 2 isolated incidences, one this year that an outside hospital outside of our system transferred a patient in for assistance with brain death and organ donation. Following authorization, the patient was transferred to Presby. But CORE is one of the OPOs that is able to transfer brain dead patients to our in-house recovery facility. And so oftentimes brain dead donors who are pronounced in community hospitals get transferred to core for donor care and instead of transferred to Presby.
Okay. Let me see what I can go to here. We're not going to get to all these questions, but there's a lot of questions that center around the engagement of the hospitalist team and a question around who does the family care at the time of donation. Is it the OPO's role? Does the OPO have family support coordinators or some other role to take care of that aspect? And are they also in the operating room if there's family presence in the operating room? How is that delineated given these different roles?
Yeah, that's a great question. The family is introduced to the team and is, knows who the DCDRN and the ODST physician are for each case, but it really is still the OPO's responsibility and really our privilege to be able to care for donor family members up to and throughout the OR and the extubation process. So if we have donor family members coming to the operating room, we have either a member of our donor family support team, one of those donor family coordinators, or in some instances, myself, if I'm available, will escort the family to and fro the OR and support them while they're in there for extubation. It's still the OPO's really privileged to be able to provide that care.
Do the DCD nurses come in to support the DCD patients, and are they removed from their other job responsibilities so that they can be actively involved?
Yes, we will come in 24/7. We take availability basically a month at a time, recognizing that we're in the middle of a pandemic. Some of our nurses are bedside, maybe staffing, that I will oftentimes pinch hit. The only time that I'm not available is if I'm teaching. But we work together as a team and always ensure that a DCD nurse is present for the case.
Yeah, we've never had to go without a DCD nurse.
And I'm looking at the time. Unfortunately, we're well over, and which is unfortunate given how many questions there still are to answer. But at this point, this was, I would say, a very engaging presentation and very rich in content. Amy and Kate, thank you very much for sharing. And I'm at this point going to turn it back to Deanna from the Alliance.
Great, thanks, Meg.
Thank you very much.
Thank you, ladies. I'd just like to certainly echo Meg's comments there and extend a sincere thanks on behalf of the Alliance to all three of you ladies for not only taking the time and putting in the effort for putting together such a fantastic presentation, but for sticking with us to help address some of these questions. I think it's safe to say that based on the number of questions we received, folks are quite interested in your methodologies and practices. And so what I'm hoping to do, if you're all agreeable, is maybe we can compile the remaining questions that we have left in the queue and maybe follow up with everyone via email. Does that work?
Yeah,
Yes.
Absolutely.
Okay, perfect. So for those of you who submitted questions that we're unable to address, please rest assured knowing that we'll compile all of your questions, have our presenters address them, and then we'll send the responses out to the entire group. So stay tuned for that. But in the meantime, we thank you all so much for joining us today, and we look forward to seeing you in the future. Enjoy the holidays, everyone. We'll see you next year.
Thank you.
Take care.
Thank you.
Thank you.
Bye.
Bye-bye.